So we'll get started. Good morning, everybody. My name is John. We're going to be talking today about transvenous pacemakers. First, a thank you to the Small Talks team and Dr. Douglas, who wrote a really great review on this topic and a couple months ago. So first, let's talk about our indications. So why are we doing this procedure? Basically, if your transcutaneous pacing is failing, if your other adjuncts are failing, like your inotropes, things like that are failing, you need something else. So you need to go transvenously. You also can think about long-term need for pacing. People don't like to get shocked to their skin for a long amount of time, so you might need this placement as well. The other thing is sinus arrest or bradycardia and AV blocks that are symptomatic. The other part is there's medication toxicities that can cause bradycardia. You got to keep in mind, though, that this is going to be part of the combination of treatment for these toxicities. It's not going to be the sole purpose that you can do things, because your heart still needs to have calcium in the calcium channel blockers. It should be part of the supportive treatment as well. And then is overdrive pacing. You have people in torsades that are converting back to a normal sinus rhythm. This is going to keep them in the normal sinus rhythm as best we can. That'll be a talk for a different day. But what are our contraindications? Basically, think about reasons that the person should be Brady other than electrical reasons. So the first is a giant aortic dissection that we see here on chest x-ray that can go up into the coronary arteries and lead to bradycardia. Another is an inferior STEMI and anterior STEMI. So this is a third-degree AV block with a junctional rhythm. Other things we can think about are pathology that affect the aortic valve and things like that. So you're talking to your patient about the risks. They include a massive pneumothorax, as seen here. Realize that you're doing two procedures. You got to first put in the Quartus, and then you got to put in your transvenous pacer. So there's two sets of complications associated with that. So first, with the Quartus, you have the pneumothorax, you have infection and bleeding. You have transvenous pacer complications of basically the migration of the wire. It can lead out. In this situation, it went. This is a permanent pacemaker wire that went to someone's rib through the heart, which is pretty wild. You also have arrhythmias and infection and microshock as well. So what do you need? Your pacemaker supply. So what's nice, this is a post from another institution, and this is actually the kit we have. There are three things that you have inside. You have the actual introducer, so the Quartus, the adapters, the pins, and you have the pacing wire. And the pacing wire has a couple pieces to it. It has the wire itself, the balloon, we'll go over this more, and it has this nice sheath that's going to keep everything sterile in case you need to make adjustments later on. You're also going to need the central line, a sterile probe cover. You're going to need your pacer, which is on the outside. It's a non-sterile piece of this equipment. You got to keep that in mind as you're setting everything up, and it's located elsewhere. You also will need an EKG machine if that's how you decide you're going to confirm placement and monitor placement of the pacemaker. And then just keep in mind that a Quartus that we need for the transvenous pacemaker is a different size than we use for trauma. Trauma can be like 7, 8, 9 French versus the transvenous pacemakers we have are 6 French Quartuses in the kits with a 5 French pacemaker wire itself. So it should be a pretty similar diameter. Otherwise, it could lead to other complications. And then you also want some more tegaderms, you want some more chloropreps, and you might want an extra kit by the bedside in case you run into any issues. So this is what our CCT looks like. These are the kits we have at Kings County. I didn't have a chance to go over to downstate and look at the downstate supplies, but the pacemakers themselves are located in the bottom of the cabinet in CCT, in the trauma bay. This is what they look like on the outside. And then you open up the bag, and this is exactly what it looks like. So you have your pacer here, you have your wire, which is again non-sterile, and an extra battery. There's actually a battery inside already. So this is a backup battery. Before you get all dressed up, there are certain things you need to do. I would first set up the box. You don't want to have to instruct someone on how to set up this pacemaker box as you're doing it. So let's go over the pacemaker terms a little bit. So first is the rate. It's the amount of deliveries of electricity or the amount of electrical activity that the pacer is searching for within a minute. The output itself is the amount of energy that we're delivering to the heart in case we need to. The sensitivity is the ability for the pacemaker to see the electrical activity of the heart. And we can think of that as kind of a fence that's kind of put up there. So the lower the sensitivity, the lower the threshold for the pacemaker to fire, the more it's going to see the electrical activity. it was a weird and counterintuitive way, but that the fence analogy I think is a really good one. So the higher your sensitivity, the more electrical activity the heart is going to be, or the pacer is going to require the heart. Sorry, I'm stumbling over my own words here. The higher the sensitivity means that there's more of a threshold for the pacemaker to fire. So we'll talk about how that applies later and how it'll be beneficial, or understanding a little bit later. Then there's understanding the pacemaker settings. So, oh, I'm so sorry. I forgot one thing before we move on. Ooh, we're jumping around here. You want to set your pacemaker to the VVI setting. So let's go over the pacemaker itself really quickly. So this is the power button up here. This is your rate. You can control the rate on the dial here. This is your atrial output. We're not going to be atrially pacing this patient, so we don't need it on. And then there's a ventricular output, which is the milliamps that you're going to need. And you're going to adjust it using the rate button here. There's a lock button to make sure once everything is set that you don't want to adjust anything anymore. You lock it so that the knobs don't get pushed and the buttons don't get pushed anymore. You also have a mode. So ours is going to be in VVI, and we'll go over what that means in just a second. The battery indicator is right here, and your sensitivity is right here, and it's controlled with the knob down here. There are up and down arrows, and depending on what setting you have it on, there are more options that'll be displayed at the bottom of the pacemaker. I'm not going to go over that today. And then there's also a pause button so you can see the underlying rhythm. It'll actually stop the pacer from working for a temporary moment. And then we talked about the defense analogy. Doubling down here. Pacemaker settings. So there's 5 letters that are associated with it. The first 3 are the most important in this situation. So the first thing that we talk about is what chamber is paced. So what are we actually looking to actually deliver electricity to? The atrium, the ventricle, both or none. The second is what chamber is sensed. So what electric current are we sensing? Are we sensing the ventricle? Are we going to sense the atrium? Are we going to sense both? Or are we going to sense neither? And then the third is what's going to happen once we do sense that? So are we going to inhibit? Are we going to trigger? So in VVI, we're going to sense the ventricle. We're going to pace the ventricle once we hit our threshold. And if the electricity is hit, the threshold is hit, we're going to inhibit that. So what do I mean by that? So in this situation, the sensitivity is low, right? The heart is able to go above our sensitivity threshold. So because the pacemaker sensed the electrical activity, the pacemaker is not going to fire because it's VVI, it's inhibited. Versus if we were VVT, in that situation, we would trigger an electrical impulse. But that wouldn't be beneficial in our situation. And then there's letter 4 and 5, programmability and anti-tachycardia dysfunctions. I'm not going to go over those right now, but those are other ones to keep in mind. So now you get prepped, you're ready, you have your box set up, you have your person there that's going to help you out. Before you got dressed, you also decided to use your ECG as the way you're going to detect where you are in the heart itself. So you have your ECG machine on. Now you're going to get dressed, you're going to prep the right IJ or the left subclavian. The right IJ is more preferable because permanent pacemakers are really put in the left subclavian. So keep that in mind. It's also going to be ease of access and compressibility and all that stuff. You are putting in a Quartus. This is a larger bore catheter. You're going to test the balloon with 1.5 mLs of air. So this is important because you want to make sure that the balloon not only inflates, but the lock mechanism will hold. So this is a lock mechanism where you push you simply push the plastic over and it holds the air in there. And then when you push it back, the air will kind of flow out and you can withdraw the air from the balloon. There are other ones where it's kind of like a 3-way stopcock. Instead of 3 ways, it's a 2-way. So when it lines up normally, it'll be flowing air. And when it holds up this way, it'll be stopping air. So just test that your balloon holds air. And then you're going to also put the sterile sleeve over the pacing wire, which is this piece right here. If you don't do this now, you're not going to be able to do it later, and it's going to be harder to keep everything sterile and adjust things later on. So I'm not going to go over how to place an introducer sheath, but the next step, now that you're dressed up, you're ready to roll, you're going to place your introducer sheath using the Salinger technique, and then you're going to place the pacemaker. So we'll go over that really briefly. So what do? We put, we have 2 options, right? We talked about that. There were a couple of options, but one option is to use the ECG machine to place your pacemaker and confirm placement. The other is to use the ultrasound machine to go into a subcyphoid view With a non-sterile person, you can't do this and place the pacemaker. But that's another option for you. You can go in blind, which not necessarily suggested. So the first thing you do if you want to use the ultrasound is put it in the subxiphoid view and watch for the TVP passing through the tricuspid valve into the right ventricle as you're doing this. So you're going to take your pacemaker, you're going to put the pacemaker into the Quartus itself right here, and it's going to go through the Quartus, and you're going to go about 20 centimeters into the Quartus. At that point, you inflate the balloon by putting the 1.5 mLs. You're going to lock it in place, and then you're going to float the pacemaker wire into the right ventricle, ideally going into the apex of the right ventricle where it's going to sit. You're going to advance further and further. So if you're using your ECG, you're going to start looking for your V1, and this is the electrical activity you're going to start seeing. As you move further and further into the atrium, basically the biggest thing you're going to look for is once you're in the right ventricle and you're kind of in the free wall, you're going to start to see a little ST elevation. And then once you're actually in the ventricle itself, you're going to see massive elevation as you're hitting the wall of the ventricle. And it's going to be positive deflection of the QRS. And then if you've gone the wrong way, you're going to see negative P waves and other morphology. So realize that if you're not in the right spot, this is kind of what you're going to see here. Once you're in there, you're going to deflate the balloon. Once you're in there, you're going to get electrical capture. Once you have electrical capture, you need to confirm mechanical capture. We always talk about that with transcutaneous pacemaking. It's the same thing here with transvenous. So you're going to feel for a pulse, or have your non-sterile person feel for a pulse. And you're also going to see if you see good waveform on the pulse ox. That's another way to do it. Then once you have that, you're going to deflate your balloon, have the patient cough. Make sure that the wire isn't going to move around once they start moving around, because that's really important. I had a patient in the SICU that happened to, and the wire was kind of all over the place at one point. Cardiology had to come really fast and fix it. Determine your output. So this is an important piece of basically what you're going to do is, remember our pacer box, we had our output set to 10 millivolts when we set up. You're going to decrease the millivolts slowly over time until you hit a part, or you're no longer electrically capturing. You're going to take that number and double it. That's going to be give you a safety margin. You don't want to go up just by 1 because that doesn't give you enough. God forbid something happens, the heart isn't as responsive anymore. Double that number, give you a wider safety margin. You're going to determine the sensitivity by adjusting the levels so that it gives you the intrinsic beats as well as paces when it needs to. So that's going to require you to stay around the bedside a little bit and just make sure that it's working properly before you leave. And then you're going to connect the sterile sleeve to the Quartus. So that's this little piece here again. And extend it all the way over the wire. And then you're going to suture your Quartus in place, and you're going to put a bunch of teggies over the wire on the sterile sheath. That way you keep everything sterile in case you need to make adjustments later on. You're going to chain a chest x-ray and a baseline ECG. That should show a QRS in the left bundle branch block and a superior QRS axis as well. This is what it's going to look like when you're under ultrasound guidance. So your wire is the metal thingy in the base of the right ventricle right here. And that's just going to confirm placement. And then you should probably call cardiology if you haven't done that already. I really like this little, I just found the most funny stock things I could about cardiology. I thought this is really funny. It's like a Super Saiyan or something like that. All right, so troubleshooting the TVP. This is a really important piece. You got to have a systematic approach, just like anything else we do in EM. Have a system that way when stuff is hitting the fan, you can kind of fall back on that. So the first thing is review the ECG and try to identify what's going on. Then you're going to check the circuit. You start at the patient and you work your way backwards to the box. Always start that way. You know, if something happened to the device, that way you can find out very quickly. And then you're going to check your box. You're going to make sure your rate, your rhythm, your rate, your mode, your threshold, and your sensitivity are all up to snuff. And then implement your backup, right? So you have to have a backup plan in mind. You can go back to your atropine, your inotropes, transcutaneous pacemaking again, and then CPR, God forbid, if we need to. And think about your electrolytes always. So a little audience participation here. We have our patient here. For some reason, every once in a while, we see this nice red dot show up on our ECG machine. And this is happening. What do you guys think is going on in this situation? So we have pacer spikes and we have QRSs, except for this one time, right? We have things going on, and then suddenly we're not getting the right output. So we're calling this output failure. Basically, the rate on the ECG doesn't match the rate that we set on the box itself. And there are several problems that can lead to this. There can be a lead failure, a generator failure, battery failure. If there's a dual pacemaker, so let's say this is a person that has a permanent pacemaker in place with an atrioventricular, it could be crosstalk inhibition. I'm not going to go into that today. It could also be something called oversensing, which we'll get to later. So we know that there's an output failure. We know that there's something going wrong with the pacemaker. So what do you want to do to kind of troubleshoot this idea? So whether we're not getting enough energy or not getting the wires. Let's go back to our, so we looked at our ECG. We saw the output failure, right? We saw it there on the ECG. Next thing we're going to do is go back to the wires and the patient. Start the patient, make sure the wire is still intact. No one cut it on accident while they were changing something. It's in place. The wire is at, it's really important to document at what centimeters you were when you placed the transvenous pacemaker. That way someone can go back and be like, oh, it's at 22 centimeters when it was at 27 before. We're clearly backed out somehow. I don't know how that happened, but that's an important piece. So you can increase your output. Increasing the output would give us more energy, and that hopefully will give you that missing beat again, the missing pacer spike again. And then if you really need to, you can then you go back to your device as well and check your power, your battery, your connections, making sure the pacemaker wires are connected properly. And then confirm placement again, put your sub-xiphoid view, make sure you're in the right spot again, and consider changing the wire, the wire, or you can start transcutaneous pacing again, implementing your backup plan. So what do you guys think is going on in this situation? The bottom one may not exactly happen to us when we're doing transvenous pacemaking, but it could happen later on. So we're firing, right? The pacemaker is working. The pacemaker is detecting that some sort of signal is not going on. And this is what we look for when we're initially setting up. So we're getting pacer spikes, but for some reason we're not getting electrical capture. The electricity is missing. So we call this failure to capture. The pacer is basically not getting the contraction it needs, and it's obviously not generating the pulse that we want. So there's two types of failure to capture. There's genuine failure to capture the pace, where there's an issue with energy. It's mainly the problem, it's too low, or your lead is broken or misplaced. So there's something wrong with the device itself. It's unfortunate that happens because you kind of start all over again. And then there's also something called functional capture, where the energy is delivered, but it's delivered during a refractory period, so it's not really going to do much for you because the heart is not at a time when it's ready to contract again. So what are we going to do in this situation? I'm sorry. Increase output. Yeah, sorry, I didn't hear you. Exactly. Yeah, we're gonna look at our ECG. We're gonna go back to the wire. We're gonna make sure it's all good. Starting at the patient, working right back. Exactly. Increase your output in the milliamps until you can get that electrical capture again. And then if it's still not working, assess placement. Making sure your external connection is in the right place again. Again, going through your algorithm. You're absolutely right. Your milliamps is your problem here. So increase your output using the dots here. What about this time? What's going on in this situation? Exactly, it's not firing. You're absolutely right. So in this situation, we have a patient on the top, let's say. So this is kind of small for the people maybe here, but you have AFib as the underlying rhythm, right? You have pacer spikes happening and electrical capture happening when the pacer spikes happen. For some reason, the pacemaker is not detecting, or it's not firing when it needs to. So this is something called oversensing. In this situation, all of the atria electrical activity is actually increasing is being sensed by the pacemaker at that point. So this may not actually be seen on the surface ECG, but it's usually caused by intrinsic electrical activity or it's extrinsic electrical magnetic activity. So that's why they have people with pacemakers shouldn't go into rooms with microwaves, or like old cell phones were an issue with people with pacemakers. It also could be caused by lead failure. So like if there's an insulation break at the lead itself, that would mean there's not as much, like they can detect more electrical activity going on. And then in the bottom one, the ventricle isn't paced after the intrinsic P wave, so it's overpacing. So what are we going to do in this situation? So it's a sensitivity issue, right? The heart is for some reason picking up too much electrical activity. In this situation, what we need to do is it's seeing too much electrical activity, right? Our threshold is a little bit too low. We actually need to increase our sensitivity, make that fence taller, so that way the electrical activity that it's sensing isn't picked up and we can fire at the right spot. And then one last one. So what's going on here? So it is, right, the pacemaker is working. The pacemaker is firing, but the problem is that it's firing at the wrong time. The pacemaker is not basically failing to detect the correct electrical activity. So what's going on here is it's called undersensing. So we're not sensing enough in this situation. Pacemaker might not be in the right spot. The lead may be broken. Again, a common theme here is like go back to your actual pacemaker wire and stuff and think about what might be going on when you're thinking about issues, but also think about your programming problems. Are they on the improper sensing threshold? Again, is there not enough electrical activity from the heart itself? And then is there any electrolyte abnormality? So in the bottom, in the top one, this is an atrial pace, so it's not sensing the atrium here. So it's undersensing. And then how are we going to fix this one? This is another sensation problem, right? So in the last situation, we wanted to increase our sensitivity because we were oversensing, and now we're undersensing. So we're actually going to decrease our sensitivity. We're going to decrease that fence so that our pacemaker can see more electrical activity and be in a better spot to coordinate the electrical activity to make the proper capture. That's it. So yeah, please. This is undersensing the atrial contraction, exactly. So this is an atrial pacemaker. I'm sorry, I don't have like strict transvenous pacer stuff going on here, but exactly what you said. So this was trying to see the atrium, but it's not sensing the atrial contraction in the situation because of the threshold is probably too it's probably too high. So this would be an sensed atrially paced, and then whatever, it would probably be an inhibited, so AAI more than likely. And because of that, it was inhibited, it was firing because it wasn't sensing what was going on here.
Yeah, so part of the language is always confusing with sensitivity.
Yes.
And as McMahon was kind of explaining, like the defense analogy, which is a good analogy, when you actually put the number lower on the box, you are actually making the pacemaker more sensitive.
Yeah.
I understand the sensitivity. What was happening?
So in this case, right, you're seeing.
Yeah.
Yeah.
Say that again, Melly.
It just kind of looks like it's a normal EEG.
It does. Right? You're absolutely right. It looks like a normal thing because it is. It's working. Like the intrinsic rate is fine or it's probably too slow. That's why it's paced. But the actual ECG itself looks normal. The problem is that the rate is too slow. It's not pacing at the right spot.
Yeah, so if you see a normal strip and there's pacing spikes in it, you say, well, why is the pacer trying to do anything? This strip looks totally fine. I don't think it needs to be there. That's undersensing. You need to make sure that it's more sensitive to pick up the electrical activity. You do that by dialing down. You lower your fence so that way that this electrical pattern can be sensed a little bit easier, not blocking yourself.
But you also see, Molly, sometimes most of the cases we're putting in are ventricular cases that we're putting in, right? So what you usually will see more common in right there is you'll see they'll have a beat, and then you're setting your pacer usually it's gonna, they'll go about 60 to 80.
Mhm.
So instead of waiting, sometimes you'll see after they give you a beat, and should then wait, right? You get the normal beat of the person. But then instead of waiting until they fail, and then your pacer saves you, you'll see you'll be getting firing inappropriately right after the beat you have, instead of waiting that long enough. So it says, oh, it's not working, and it's less than 60 minutes. I'm going to go ahead and hit it. That's where you'll see it more. It's failure is sensing it's not needed. And so it goes ahead and it fires, even though it's not needed. And sometimes you'll see a fire being captured too soon. That was
Please,
great.
Thank you.
A couple comments.
Please.
When again, remember when you're doing it the way he showed, which is the right way, that when you're looking at the cardiogram to see where you are, whether you're in atrium, whether you're in the ventricle, whether you hit the wall, remember you're recording off of the V-lead. You're not recording a regular EKG with everything on. So you're connecting your alligator clamp. It's going to be to the negative of the pacer. So you're actually recording from the pacer itself.
Mm.
The other way to do it, if you're desperate and it's not working, especially if they have very low voltage, let's say someone almost did a rest or something, is you're desperate. You can hook up the pacer right to the box the whole way and turn it up high, right? So you're delivering a lot of voltage. Again, you might cause damage, and then you're playing with it and hoping you'll start to see it pace. That's kind of the desperation way to do it, right? You'll see that done sometimes. You just start the pace and hope it'll capture, and using very high voltage output on the thing. You'll sometimes see cardiology do that.
So just a quick summary, just keep in mind thank you very much, Dr. So just keep in mind your devices and what you're going to do is two separate procedures. You review the terminology and how you want to set up a pacemaker rate of 10 milliamps, and your sensitivity is around 2. And then always fall back on your training. So look at your EKG, look at your device. I'm sorry, look at your hardware, and then look at your device, and then keep calm and be in an EM position, and work on your backups as well. Okay. Any questions? Please.
Can you go back to your diagram of the whole thing?
Just wait, which one?
Keep going. That one.
Just thing.
Just, I forget if you said it. It could be pretty basic, but it's important. You mentioned you have to go 20 centimeters and then inflate the balloon. Just point out the markers for everybody.
So yes.
If you've never done it before, you might not realize that.
So these are the markers here on the transvenous wire. You have basically every dash is another 10 centimeters. So you go to 20, so 2 dashes at the level of the Quartus, and then you're going to inflate your balloon. That way you're in the central venous system and you're out of the Quartus, and that's when you're going to start advancing. Yeah.
You don't want to inflate the balloon while you're still in the Quartus.
Yeah.
Abort everything.
Very bad.
Open a new case.
Yeah.
And then the sheet thing, that's one of the things that technically that we sometimes forget. And that you did a good job of highlighting that. And that's important because of exactly what you said. If it gets displaced, you need to have sterilely move it in and out. So if that's not there, then probably technically we should put in a new pacemaker every time it gets displaced.
Yeah. Any questions?
Very good.